Hello, good afternoon, and welcome to our session this afternoon, Educating for Outcomes. My name is McKimm. I'm head of quality at the BMJ Group, and I'll be joined in a second by my colleague Helen Morant, who's head of online learning. This afternoon, we're going to hopefully talk you through how we can improve our understanding of how to use patient outcome data to drive improvement. We're going to try and realise the interface between improvement and education programmes. And then hopefully together, we're going to hopefully blend different education improvement techniques. But first, I wanted to tell you about my weekly grocery shopping. And there is a point to this, I promise. And I should also point out that my grocery basket has never, ever looked as healthy as that one. This is Tesco. Tesco is the UK's largest supermarket chain. It's the third largest in the world, behind Walmart and Carrefour. But back in the 1970s, Tesco's was trailing behind the competition. It was known for poor quality and known for its badly managed stores. One of its biggest problems was stock management. They found that they had excess of one stock but ran out of another product. And they needed to find a way to understand what the customer needed, but more importantly, when they needed it. So they introduced something that's very special. Something that's been replicated by not just supermarkets, but other industries around the world. And they introduced the Tesco Clubcard. And the Tesco Clubcard isn't special because it's a reward card. It's special because of the data crunching and the analysis behind the scenes. They know, for example, what breakfast cereal you're likely to purchase next. They can also, by analysing all the shopping data, work out when you're likely to run out of things like toilet rolls. And even more intelligently, whenever you purchase, for example, a pregnancy test kit, they can anticipate that perhaps in a years down the line, you may be interested in purchasing baby nappies, so they can send you vouchers for that. What's important to remember that this was done back in the 1980s, before online shopping, and well before things like Amazon. And if you need to see the power of this in action, if you've never shopped at Tesco online before, if you register for the first time and put in your Clubcard number, they'll work out from what you bought in shops over previous years what you may buy online and create an idealised shopping list for you. So they can automatically anticipate what you might buy. For those of you who already shop with Tesco's, you probably realise that every couple of months you get vouchers. And a third of these vouchers are personalised exactly for you. So they can try and anticipate, they can try and upsell, move you to different brands based on what you've been shopping in the store for before. And it's not just Tesco. You probably noticed that these days, every online shopping experience is trying to predict and recommend what you might need. So what's this got to do with healthcare, you might ask? Well, if we can take this model that Tesco use and use it in healthcare, we can try and do some really interesting things. So what we can try and do is predict what the individual needs of health professionals are. And if we can do that, then we can deliver learning intelligently around their clinical duties. And we also know when they need to restock or refresh their professional development throughout their career. And this is an issue because of a couple of things. One of the biggest problems in quality improvement is this knowledge overload. And it's amazing that every 5 years the amount of medical information we have doubles. There's over 100,000 randomized controlled trials done every single year. And what's spectacular is it takes an amazing 17 years to get that knowledge into clinical practice. And if we want to take some of the stuff that we've learned this week and apply it to improving healthcare, we need to speed that process up and make sure it becomes routine practice. So let's look at how we compare to Tesco's. I think on a national level, we seem to be doing pretty well. On a national level, as far as working out what our learning needs are, we do a pretty good job. We take some financial pressures, what national budgets are, return of investment of different learning techniques, blend this with some regulatory measures around national guidelines, looking at standard levels of safety. And then we benchmark this against clinical practice, so looking at how we compare with other countries and look at variations in care. And we pull in a bit of evidence there about what we can and what's been shown to improve. And out of that, we set national priorities. So we set the topics that we want to concentrate on. In the UK, for example, we've just had a national COPD strategy, And this is partly because we know that benchmarked against European countries, we're very bad at things like mortality and morbidity. And we also know that there's very strong evidence that we can improve COPD care. And we know there's good case examples of where this has been done. More interestingly, though, on a local level, we're starting to do interesting things. So within our organisation at BMJ, we've been working with primary care organisations, a new product that we've got that helps to audit what happens in primary care. And BMJ Informatica has been looking at how we can measure variation in performance in primary care. So we take general practices in the community and look at how they're performing in a lot of detail against various things like diabetes, COPD, and particularly in public health. We've done a big project in Medway in the UK looking at how we can improve things around smoking and obesity. And we can then deliver personalised learning programmes to those practices to help bring them up to the level of others, but also help them to learn from other practices that are there. But we think even more interesting from that is going right down to that granular level and taking individual clinicians and healthcare professionals. If we can work out how individuals are performing and whether they're performing badly and performing well, we can deliver very personalised programmes. And the hope is that we can automatically identify you as a doctor or a nurse or another health professional what your learning needs are, and then we can deliver it to you intelligently around your clinical workflow. So it may be at the point of care, it may be outside your work hours. And we can also then measure over a period of time whether this intervention has made an improvement. And we started doing that. We started looking at individual doctors. So we can take Dr. Smith, who works in a surgery, and compare them against other GPs and see whether they're perhaps underdiagnosing different conditions, for example, COPD, or if they're overprescribing for things like diabetes. And if we suspect they are and we predict they are, we can deliver personalised learning to them to help them improve that activity and then show them how they're improving. So I think that's something that I want you to keep in your mind during the session this morning. We're going to do some work at building our own programmes later on. But I want to hand over to Helen now, who's going to talk about how we can learn to improve behaviours to drive clinical and quality improvement.
I'm speaking from these mics, so good. So I'm head of the online learning service at BMJ, and our job is mainly creating e-learning at the moment. But I think a lot of the things I want to talk about is how our job's going to be changing and how we need to address those issues. But to ground us, this is what we know. There is some quite good evidence for medical education, fortunately. And these are the things that work. So mixed multimedia presentations of information, we know works. Repetition, we know works. Repetition, we know works. Interactivity works. So it's important that we remember that those three things are sort of at the centre of everything we do. The other good bit of evidence there is in the medical education world is for these things. So one of the questions we're often confronting is, how do we prove that it's worth educating people? How do we prove that it's worth it? And what it comes down to, of course, is the bit at the bottom, the patient outcomes. And unfortunately, that's where the evidence is weakest for education having an impact. And that's because it's really difficult to link an activity that a single healthcare professional does in isolation to patient outcomes. We know we're good at getting people to build their knowledge up. That's what education's been doing, and testing for ages. We're getting pretty good at testing attitudes and skills so that we can prove that people's attitudes to certain scenarios and their skill base, certainly through simulation, can really be improved through education practices. And we're quite good at changing behaviour. So the behaviour of healthcare professionals, we're getting there with that. There's good evidence that it's worth trying to change behaviour through education. But if you look at those top 4 things, I think it's really clear when you think about either from a quality improvement perspective or from a medical education perspective at least, what you're actually trying to do is make patients better. So the reason any doctor will read any journal at any level will be actually because they're interested in doing their job well, and their job is to treat patients. So I'd like you to sort of keep in mind that knowledge and attitudes, to a certain extent skills, and to a certain extent behaviours, are only proxies for changing patient outcomes, because they're what we can measure easily in education. So this is the bit where I hope the video works. This is one way of looking at it. We know, don't we, that there is a thing called a quality improvement cycle. And we know that that is driven by data. You've got to collect information about what you're doing to prove change. We know that education works on a similar cycle, so that we have exams, you learn more things, you have more exams, you learn more things. And we know, as Ashley's been describing, that our data is getting better and better about those patient outcomes. We can collect a myriad amount of data. And what I'm hoping we're going to be working towards over the next 5-10 years is a way of getting that data to drive both quality improvement and the education cycles together. I'm so pleased that worked. So, how to merge improvement and education. And a lot of the thinking I've done on this is pretty much my reaction to a paper in the Annals of Internal Medicine from February, which is brilliant. And I've put these thoughts together to sort of really stimulate debate amongst us, and I want you to challenge what I've said about these things. There are different ways of doing it. The first way is to sneak improvement into education. I call this infiltration. We all think quality improvement is a really sexy topic and we love it. That's why we're here. We also, probably most of us, know that it's quite a hard thing to get other people involved in. So sneaking stuff in might be a good idea. Enhancing education with improvement is something that, as Ashley's described, this thing of assessing needs, knowing the needs of the population through the data that the improvement movement is gradually building into practice. That's a sort of evolution of education. We're making the education better by informing it. There's something else going on as well. Giving education credits for participating in improvement projects. Now, I think if you think about this for a little while, you'll realise this is actually the revolution that I sort of mentioned at the beginning, because it's no longer about increasing knowledge in a population of professionals. It's about actually improving the outcomes for the patients, and that's what we're rewarding them for. So there comes a point where you think again about this list and you think, well, why do we need the proxies? Why don't we just go straight for the outcomes? And I'm not sure whether there's been a lot of thinking about how that's going to play out in real life. There's certainly a lot of things going in. So I'm going to go into these in a bit more detail and work through some examples. Now, did you notice you had something on your chairs when you came in? They weren't reserved signs. You pick them up. Everyone should have one, or everyone should be near one. Good, some nice rustling. Excellent. Now, on the one side, you will have a word which should not be the same word as your neighbours, and on the other side will be a definition of all those words in case you need a bit of help. But if you just listen to what I say as you go along and notice when your words come up, if you've got a yellow piece of paper, that just means you're special, and I'll explain to you later. So, sneaking improvement into education. An example of this would be an interactive webinar on diabetes that is planned for a group of doctors who are working in a high-risk area for diabetes. So because you are being asked to educate this group of doctors, this geographical population, you plan to do the subject of diabetes, which you know from the data they are at risk of suffering from. So that's your first sneaking it in. You're not saying we're doing quality improvement, you're just saying we're doing diabetes, and they'll learn. The other sneaky method, and I use the term sneaky as if it's a really good thing, because I think it is sometimes. Quality improvement topics included alongside clinical topics, and anyone who works in education and quality will know about doing this one if they're asked to talk on anything clinical. An example would be an e-learning course about depression, where you're asked to put together an e-learning course about depression for whatever group. And with that group, you talk about the importance of setting up screening programs, as well as a discussion of how the drugs work. And that's a way of sneaking in the fact that the process by which the care is delivered is as important as the pharmacology of the care. So enhancing education with improvement. This can be done after an educational event, and there's still in a great amount of the world a thought that continuing medical education happens at events. We're all at an event, so it must be at least partly true, but it's getting less and less true. But let's think about a webinar as a new way of attending an event. So it's an online event that you don't have to leave the office for, still an event. You might encourage the participants to that event, the webinar on pain relief, to survey their patients afterwards and get their patients to report on things, and then produce a report on their findings. So that's enhancing the education by getting them to think in an improvement way about collecting some data about those things. You can enhance education by bolting something on before the education event. So, as we said, one important part of education we know is mentoring schemes. And so there may be a mentoring program that's available to people, but it might be important that someone puts in some time to assess what their needs are before they go on that mentoring program. And that's another way of improving the quality of that mentoring, because we know what the needs of the participants are. And then this is the final one, giving education credits for participating in improvement projects. So I've just done here a very broad outline of the performance improvement CME credits that are happening in the US. We know if you work in the UK, you'll be aware of people being encouraged to do audit and getting credit in revalidation and areas for these sort of things. But this is a US model, but it's a useful way of thinking about it. 3 stages: assess, apply, and evaluate. The assessment would be about collecting some clinical measurements through chart review. So an example might be reviewing a group of patients with Alzheimer's medication charts. Applying that would be putting a change in practice in, which would be something like establishing a regular review of medications, which might be the change in practice that you need to see to ensure that they're not on any medications they shouldn't be, or anything like that. And then the evaluation, and this is the important bit we need to remember when we're talking about giving education credits for participating. Everything is becoming a lot more formal in education these days, and maintenance of certification, revalidation, appraisal. If these words aren't sending off little alarm bells in your head, then you probably they will be in the next 2 or 3 years, because these things will affect all healthcare professionals. And this is being able to report and reflect on what you've done. So an example would be assessing the cost savings and quality of life measures gained by making the change, and using a reflective template to do that so that it can be discussed with your appraiser at a later date. So these are all the words you have in front of you. And your task, should you choose to accept it, and I hope you do, because as we all know, interactivity is a very good way of learning. What we want you to do is blend the resources around you. And by resources, I mean people with bits of card. You are a person with a bit of a card, and there are people around you with cards, and they have different things on them. I want you to talk to the people around you, see what you've got, see what you can make. For a population you know, or, and this is where your yellow card people come in, one that has been suggested. So if people with yellow cards can hold them up, and spin their cards around so people can read them. It might be that you've lucked out and got your favourite topic, and you want to do something on that. Fantastic. It might be that you're short of ideas and want to create a programme around that. If you really want to create a programme around one of the yellow cards, go up to that person and say, look, I'm e-learning and I want to do something exciting to improve health for this population. And so get together and create an improvement programme and make it educational. So I would suggest you look at either the evolution method or which is this one. So bolting on to a webinar or another education thing, a survey or something like that, needs assessment. That wasn't me. But it woke you all up, didn't it? It's fantastic. So you're all now chatting. You can crack on. So it's either an enhanced education with improvement or a performance improvement program along the lines of this one that they use in the US. But there's 8 or 9 different topics. There's a bunch of different things, and we'd like to give you 10 minutes to do that. We'd love it if one member of your group is prepared to talk about that program. We're not going to get through everyone, but we do need a few of you to come so that we've got more things to discuss, and then we'll discuss those in 10 minutes' time. So, go.
Okay. Let me go get my water. So, nope. This mic's on.
They're feeding that, and then
Yep.
we'll take questions.
Should we have some roving mics from Ali and Catherine?
No, really not. They come to the sound.
Okay.
My repetition joke did get lost, didn't it?
Look. Okay. So which groups are working?
These have stood up.
What's
so
actually
that's
called
it.
C? Should we get 2 groups that are doing the same topic, so 2 Alzheimer's groups?
Yeah.
So we'll speak to one group and then we'll get somebody else. Who else doing that?
I have a list of the clinical topics.
We've got half an hour to fill. So what I'll maybe do is that if you want to go back to the podium, I'll do the lead thing, but if you go back to the podium, then I can walk around my roving mic.
That's a good idea.
So I can actually go down to the floor and kind of...
Are you sure your mic stretches out?
Should do, yeah. I'll try and get this group to Alzheimer's, and then I'll get another group from somebody else doing Alzheimer's, get them onto the mic, and then we can compare and contrast 2 different things. So you can ask questions as well.
Yeah.
We shouldn't go out into the audience and help them, should we? Should we go? I'm going to go find a couple of good ones, and then we can comment back. We can say what groups can we bring in and stuff like that. So you go that side, I'll go this side. guys going okay?
I think so. Yeah.
They've announced it to the entire conference.
We'll have another 2 or 3 minutes so you can draw all your thoughts together.
Yeah, we'll do so.
Right then, feedback time. Who's got a really exciting project that they'd like to share? Because someone's going to have something.
So I came across a couple of really good ones on this side, and I have to say we've got standing microphones. So what we're going to ask a couple of people to do is perhaps get up and tell us about what they've done. And the aim for sort of the next 10 minutes or so is really to talk about what you've come up with. Because I think there's some really good ones, a really good one up there in COPD, one down in Alzheimer's. And we're going to talk about some new innovative ways that people have thought about delivering things like webinars, doing needs assessment as well. So any volunteers, if you can raise your hand if you think you've got a good project that's been put together by your team. One over that way.
Ready to go.
Hi, we had the topic was depression and self-harming young adults. I'm a diabetologist, so this isn't my patch. We thought it was probably a project that was a little bit bigger than 10 minutes to work out, but we managed to use most of the words, so the spaghetti soup worked. We wanted to measure the frequency of this. And we decided that we wanted an objective at the outcome for this. So we wanted to reduce the number of visits to hospital by depressed young adults undertaking self-harm. And so we wanted to measure how frequent it was, and we wanted to do a patient survey to understand what the issues were for them. We also needed an educational needs assessment of the people who would be delivering their care, and we also needed to understand where and who and by whom that care would be delivered, because our objective is to prevent admissions as well as to manage them when they hit the front door of the hospital. We thought that that needs assessment would help us to identify learning needs, and that would then inform a program. We had lots of letters, lots of things to do, so we had a webinar to do, but we felt that there may be other things that were needed as well as a webinar, in particular mentoring from people who had existing skills in this into areas where those skills weren't currently embedded. And then we would need to remeasure against our original intent to see whether we'd made a difference, and then go back round the cycle. Does that feel about right?
Well, it feels very comprehensive. Was there anything missed out? I don't think so. I think the two really great things you did there is think of an objective, and I think in hypothetical situations like these, which they are, it's really good to have something solid to work towards.
We had a very wobbly moment because we realised that at the point at which people decide to do self-harm, they haven't got anyone much around them necessarily, and therefore the people who might help us to prevent it, we're not sure who they are.
And I'm not sure about the answer to those things either, but I think it's really great that you identified those questions, and that's what sort of these exercises are about. Have we got anyone else who's got the same topic? Would you like to come to a microphone and tell us what you did? There's one just in the middle here. It'd just be very interesting to compare those two things.
Yeah, we did pretty much what you've said. We had depression and self-harming young adults in the setting of an emergency medicine department. And just as you said, we thought we would actually survey the depressed, self-harming young adults as to why is your service not so good? Does it take a long time for people to see you? Are the doctors not quite au fait with the treatment? Do they talk to you in a way that isn't beneficial? So some kind of assessment of the patients themselves. Then we had a variety of cards. We had e-learning, we had a mentoring, and process review. Process review was what I've just described. E-learning, we thought we could have it kind of at the beginning, at the end, a sort of what's your knowledge like now, sort of thing, and at the end, has it improved? And the mentoring aspect would come in, and we thought perhaps a mental health nurse, someone that's an expert in that area, could actually shadow the doctors that have done this and see how they're actually doing and how all this sort of education has helped them.
Great. Those two both sound really excellent starts and slightly different approaches, but... And of course, it's worth mentioning as well that all the things that you've suggested are just a result of our brainstorming. They're not a comprehensive list of all the things there are. There are many more, but thanks to you two very much for kicking us off. Let's hear from over your side, Ashley. Anyone?
Well, I think what's important as well, I thought this was fantastic because we did sort of the measurement before and afterwards, and we put in lots of new stuff like needs assessment, which is becoming more and more mainstream these days. What would be good is, as we do feedback, if any of the people in the room who have done work like this before, who've done needs assessment, who've done mentoring, who've done and delivered webinars, if there's stuff that you feel is very innovative and very special that you want to share with everybody else here as well, do sort of raise your hand and we'll try and get you to share your thoughts with the audience. The hope is that we can kind of learn from each other this afternoon. There was a couple of really interesting ones on this side. There was one that was down here. I don't know whether you're happy to feedback, or we've got one from COPD at the back as well. Any volunteers from this side of the room to kind of stand up? We need to be better than that side of the room, so we need a couple of goods. Fantastic, let's go. That was the Alzheimer's one, was that right? What was your topic? DVT, that's the one, yeah, perfect.
Right, so ours was DVT for a wheelchair-bound adult. So we first wanted to say that everything was done in a culture of safety that was embedded within the team, and there was no hierarchy. So first of all, we started with reporting, and that was the multidisciplinary team was reporting to those of us who were starting this kind of PDSA cycle. This included then a patient survey that identified potential pitfalls and identified what mattered to the patient. So this was empowering and could start for a mentoring process. Then we used the information from the reporting and the patient survey for a process review, and this incorporated a needs assessment, and this identified our clear aims and our measures. And this then went on to educating the team to what we found and why it was happening the way it was. And we could possibly then start e-learning, a module for patients and then also for healthcare professionals. And we could start the PDSA cycle again and do remeasurements. So
Great.
That's what we did.
And it sounds like you, again, built in all the different components to make it a very streamlined process. And again, doing a measurement before and afterwards. I think we've had a couple of teams who have mentioned mentoring today, and it's something that always crops up. I don't know whether anybody here has used mentoring as part of a sort of a learning program for quality improvement in the past. Has anybody been involved in putting together mentoring programs that they might want to be able to tell us about what they've done? It is something that we know is very effective, but often people feel that it's a difficult process and it's something that they may not be able to do well. And I know some people in the room here today have done really good programs, and it'd be really nice to kind of be able to share some of that learning this afternoon. But perhaps we can come back to that in a second. We'll take one more example from this side of the room, it's okay, and then we're going to do some analysis of those. So any more volunteers from maybe the middle section of the room or the left-hand side? There was a really good group of young, I think, junior doctors up at the back who did a COPD program. I don't know whether you guys would be fantastic.
Okay, by no means am I an expert in COPD, so apologies if anything's incorrect. So we decided the aim of our education intervention was to reduce the hospital admission rates for COPD from primary care. So we initiated it with data collection, looking at GP admission and referral statistics, and also data from patients, what matters to you. And then we thought we'd integrate all of that into a webinar sharing good practice, and really sort of focusing on two things. First of all, encouraging doctors from perhaps lower performing practices to seek mentorship or to engage mentors from high-performing practices. And secondly, also providing a needs assessment of the practices themselves and working out what services they can and can't provide and what things could be improved. And then we thought we'd integrate all of that into providing feedback on a sort of 6-monthly basis on COPD admission rates and readmission rates, and then integrating that into a sort of a continuous learning process.
You talked a bit about doing that needs assessment, and what sort of things do you think you'd want to measure as part of that needs assessment? It'll
probably include surveying the range of the multidisciplinary team there, so the COPD specialist nurses, as well as the doctors, and working out what tools they think they could use, what bits of knowledge they think they lack in terms of being able to diagnose COPD, and what things they think they could improve upon.
Yeah, fantastic. And I think it's a lot of sort of educational teams these days have cottoned on to the fact that before we even start doing electronic learning or delivering education or conferences, that we need to really work out what is key to help that understanding as well. And I think needs assessment, that personal needs assessment, where you can work out what an individual person might need, is very, very important. Thank you very much. That was great. So I think we want to kind of go into now a bit more of a general discussion. We want to talk about sort of new ways that people are innovating to do each of these components of a learning program. And I think the way we want to try and facilitate this is through both questions and discussion. So I don't know whether anybody within this room, out of the discussions they've been having over the last 12 minutes or so, has any questions that have come up about how you might be able to do certain things that we can have a bit of a discussion around. So that was a question about e-learning that I think generally we feel it's a good thing for those who've got access. It's obviously is for people who are able to have access to the internet and be able to, or for literal populations who can do that. I know from our experience of delivering online learning that it does cause issues in certain parts of the world that we may not have the resources for that. Helen, do you want to say a bit more about that?
Yeah, I think it's a really important point, and I think one of the aims of the exercise was to look critically at all the different things that are available to us and work out when they'd be useful. So, for example, if you'd chosen to look at the self-harming young adults, you would absolutely want any education that you might be aiming in the self-harming young adults themselves direction to be online if they were, a UK-based population or in a developed country where there was lots of online access. And if it's a developing country, mobile phones. I mean, thinking about those sort of things is actually really important to working out what blends well with what else. So absolutely recognising that is really important, yeah.
And I think the other thing you picked up on was the patients, that traditionally we see e-learning is for health professionals. But more and more these days, we need to try and think about how we help patients to learn how to manage themselves. And that's a completely different topic. We're doing some work at the minute around trying to create electronic learning for patients to manage long-term conditions. And people say, you shouldn't really be doing that because a lot of people, if we take COPD, for example, aren't going to be able to have access to the internet. There's going to be that divide between the group who can and the group who can't. But we're testing this out. I think the feedback has been really good, that patients really, really want to engage in improving their own care. So a patient wants to learn how to manage exacerbations better, what to do if they have problems with their medication. And we can do that much more interactive through videos, keeping it nice and simple. And also patients love the fact that they can do a learning module, print out a certificate and take it back to their doctor and say, look, doctor, I'm engaged in looking after my condition. They really like that, and I think the doctors appreciate that as well. It kind of gets their buy-in to their own care. Any other questions or comments from the discussions earlier?
Any Any feedback on the exercise? Oh, do we have a question? Brilliant. Thank you.
Well, not really a question, but just a small remark. What strikes me is that the success is in the combination of the factors. And every example you hear, and we discovered it pretty soon, and well, I really liked it. I just wanted to share that.
Thank you. Yes, we agree, but I think one thing this exercise demonstrates is that it's great to have the ideas, isn't it? And it's not actually that hard to, when you start thinking, how do I put these things together? What would work well and what would be fun? That's fun, but implementing those things can be really quite tricky. Another question, comment.
This might be slightly off the topic, Ashley, but I think your suggestion of educating patients with long-term conditions around self-management, which is an absolutely fantastic idea. I just wonder what thoughts you've had around the needs assessment, the educational needs or the learning needs assessment that goes with that, because, of course, people see their personal needs in a very, very variegated way.
Yeah. I think there's a couple, we've done a little bit of thinking around this, and there's different approaches to it. In the UK, where we're based, there's more and more push for GPs, general practitioners in primary care, to prescribe stuff other than medications. So GPs these days are prescribing exercise programs, health eating programs. We see the day where a GP will prescribe an education program for a patient that does have that component of needs assessment in it as well. So we see needs assessment coming not just from electronic means, but coming from a health professional who's met with a patient, who's discussed with them, who understands their problems in improving their healthcare, and then prescribes an approach where hopefully there's an outcome that they can then bring back and show they've done it. The other approach is what we're using currently for clinicians is the intelligent needs assessment, where we can put a patient onto a learning program, an electronic learning program, which adapts automatically to their level of understanding and knowledge. So it's this intelligent needs assessment where it asks them the question about their condition. If they have trouble answering it, it makes the question easy. If they understand it very well, it makes it more and more complex as they progress, so it adapts to their level of knowledge. So there's two ways we're doing it. But I think it's only just, it seems to be, as far as education to improve outcomes, patient work's only just beginning. So it's a new area, I think, for everybody, and we've got lots to learn as well.
One of the things that I found fascinating is that we've just really enjoyed an exercise which was as far as you can get from e-learning. We're physically talking to human beings, and one of the things that came up in our group was when she talked about organising webinars and e-learning, we all pulled a face. And it wasn't just the silver tops like me. And I do webinars, and I do know how the computer works, but the power of individuals interacting with each other, of patient support groups, patients learning from each other, of health professionals learning in a multidisciplinary team when we can see each other and that interaction face to face. I have no problem with it being supported by e-learning. I have a problem with the idea of it being replaced by e-learning.
And I'm slightly biased here in being involved with the forum this year, but we don't think it will be. And, for all the previous events that we've done that you're at here this week, we've lots of online videos, we've lots of learning, but it's actually the connections, the networking is why people come back year after year, and the forum's getting bigger and bigger. It's that learning from each other, that interaction, that networking that's really important. So we see them all kind of linking together. And even on, I think Helen might want to say more about the smaller masterclasses that are really important in driving that learning. I think it's very difficult, we're finding as the forum gets bigger and bigger, that we still want to keep those personalised sessions. The learning really happens in small groups. And that's why the forum's quite special in the fact that it has so many different streams running at once. But we also run very small masterclasses, and I think you might have some feedback on that.
Yeah, I think there'll always be a role for meetings. There will always be a role. And I think the other thing about what you said is what you're saying isn't just a hunch about how you feel about meetings, that we definitely get an event like this. It's borne out in the evidence. We know that the more different media you use, and this is one medium, me talking to you, and you talking to each other is another medium, and reading something is another medium, and listening and watching videos, the more different things you put into a learning package, the more effective it is. And the more interactive it is. And the interesting thing I think about interactivity is if you ask people, they say, no, a lot of people say, no, I'm a reader, I'll just read, thank you very much. Effectiveness is proven through forcing interactivity, which is why we made you do that today.
So I think, and I know we could talk all afternoon about this, but I told off so many groups this morning for overrunning that we have to finish in time now. So I'm going to sum up very quickly, but we certainly want to try and carry on this discussion afterwards if anybody's staying around for coffee during the break. So just to kind of summarise what we've kind of discussed this afternoon, I think that new technology is allowing us to understand needs of learners like we've never done before. But taking that comment from over there, that we certainly never want to replace the face-to-face contact and the small learning groups that really help to share that knowledge. And as we've demonstrated this afternoon, I think anybody, no matter what your role in healthcare is, you can build an educational programme that delivers quality improvement for your audience. And again, we're slightly biased, but we feel the potential for learning improvement is huge. We feel a very big part of quality improvement and safety improvement is really about learning. It's about communicating how each member of the clinical team can improve quality and safety. One thing before you go is that we're really looking for feedback, looking for new ideas, looking to hear what people are doing. So if you'd like to be involved as we progress through and help to develop new learning programs for quality and safety, drop us an email with the subject Educating for Outcomes, and we'll communicate with you and share what we're doing, and also hopefully hear back from what you guys are doing as well. And thank you for joining us. Do please stay around if you want to discuss things with us, and hopefully we'll see you over the next couple of days. Thank you very much.